Richard is head of section obstetrics and gynecology at the University of Edinburgh. Welcome, Richard. Thank you.
Thank you very much, Mauricio, and thanks very much to the organisers for the opportunity to speak at what's been a really outstandingly enjoyable conference and fantastic quality discussions and presentations. So I was asked to discuss the question of whether oncofertility ought to be universally accessible to all. I have a disclosure. So what I'm going to discuss today is this concept of why oncofertility is needed, give a bit of a background to this, to discuss then where that leads us to, into how this actually brings up quite a lot of complex questions about this whole question of access to all and how one might implement that and how one might assess patients in this context. And then that brings on the final question of whether intervention is required. And of course what the question doesn't really specify in the title is it access to all for discussion or access to intervention? And I hope to explore some of those issues today. So the term oncofertility is quite widely used in this context. I'm not sure I'm a huge fan of the term, but at least for today's context, it very much allows us to focus specifically on cancer patients rather than the actually very wide number of patients for whom this whole concept of fertility preservation is relevant as well. So as I say, we're going to stick to the cancer environment for this. And the reason this is becoming such a big topic and so much part of mainstream reproductive medicine is that oncologists have really turned the thing around in recent years. And you'll see this change in survival over the last perhaps 30 years. And for our context today, we are dealing with a lot of patients with breast cancer. And you can see how since the 1990s, the early 1990s, there's been substantially improving survival for this. But this has come about because oncologists realized that this was not a surgical disease, this was a disease that required chemotherapy, and that has made a huge improvement in survival, but of course that comes at substantial cost, both short-term side effects and the long-term consequences of these very toxic agents. Pediatric oncologists, of course, have been even better at this, and they have really transformed conditions that when many of us, those the older half of the audience here, when we were children, conditions that were absolute death sentence in those days are now survivable, and the vast majority of children with cancer are now going on to cure and in many cases cure and at least very long-term survival. So that means that our clinics are going to be increasingly populated by young adults who have been through this whole process, been through these surgical, radiotherapy, chemotherapy regimes, and are wanting to address their fertility. And this, I think, is important to recognize that it's not something I'm going to discuss in depth today, but I think it's important to recognize that this is part of a broader survivorship agenda, as it's often called. And most cancer survivors will have significant health issues, not just fertility, but a whole range of other issues. And some of them are medical, and some of them are going to be social. And perhaps for our particular purposes today, one that I just wanted to highlight was this impact on social functioning that is very much an issue for patients who've been through brain CNS cancer treatments in particular, who have a substantially reduced chance of becoming married, of being in long-term relationships, and that will affect, of course, their fertility in a social rather than the biological way. So we have a broader context to try and appreciate here as well. So we can start off with this sort of simplistic view that cancer treatment is bad for reproductive function, and I am going to very much focus on the female side today, although the title didn't specify that. We'll mention males here and there, but it is very much going to be a female side of things. And we can see here the sort of simplistic idea that cancer therapies are going to deplete your ovaries of their follicles. That's a non-renewable pool, so will ultimately result in premature ovarian insufficiency, estrogen deficiency, and infertility as a previous event before that. But of course, this is just a very simplistic way, and what we really have is a much more complex and much more variable picture reflecting both the different treatments that women are going to get and, of course, the individual susceptibility within individual women to take through this. So we can go from this what is very often post-treatment amenorrhea to either no recovery, and then you have obviously got permanent infertility, and of course the estrogen deficiency, which is very much part of the problem that these young women are going to be facing, as well as the loss of their fertility. Or a degree of recovery, potentially of variable duration, potentially long enough to have a window of opportunity to have one's family or complete one's family, but sometimes not. And then that assessment there is going to be really critical for what our patients are going to be requiring from us. It's to say, where am I in life in this situation? What is my chances, you know, as a 20-year-old of having the family that I want? So this brings in really a huge area of different issues that we could spend actually a lot of time discussing. And I really just want to sort of highlight the fact that there are issues rather than go into them in any depth. But we can see on one side, well, maybe what the question of the title is really addressing is this is a universal problem that everyone needs to be engaged with this. Everyone needs some intervention. Everyone needs to have their even quite small risk addressed as well as reproductive medicine possibly can. Or do we say, well, actually, this isn't going to be a huge problem for a very large proportion of patients, and actually we want to just focus on those where there really is a very clear issue. And that will have a lot of implications and will be very much based upon how the health system in your country is going to be organized, and will vary hugely from how much the state is prepared to pay for this. And of course, for patients themselves, as well as this, they are dealing with a huge amount of information that they've just been landed with, this life-threatening diagnosis, the large number of often very unpleasant investigations that are going to be going in, this whole information overload that they're going to be absolutely subjected to. So a time of huge stress and trying to think sensibly about something that may or may not be an issue for them, potentially in 20 years' time, depending on their age. So we have a huge problem relating to this. But I think the key thing that is important at this stage, that is absolutely already clear in this field, is that actually the provision of information is of huge benefit to patients, and is already well established that this actually helps patients in the long term, just having that consultation, having that accurate information, and they then, later on down the road, there are already large numbers of studies that show that this improves their outcomes in terms of less regret, less decisional conflict. And there's an awful lot of work going on around the world trying to improve on that, and there's still a lot to be done, but I think that is already something that we can say with some certainty. So just to sort of remind ourselves of what potentially, as reproductive medicine specialists, we can offer in this context. And I just wanted to highlight that, of course, we have some very well-established things over the last decade or so. Oocyte vitrification, of course, has become completely established and fairly routine. Semen cryopreservation, of course, has gone on for many, many decades. Again, very straightforward. But particularly for children, both males and females, the options remain experimental. And of course, we are, by definition, dealing with sick children with cancer here, very vulnerable, potentially very immunocompromised, open to these things, these invasive procedures going wrong. So this is some aspect of it that we need to take very seriously. We have the potential here for doing our patients significant disservice by excessive intervention. So that's something to remember at all times, particularly, as I say, in the context of children in this situation. But, of course, this whole field has become very mainstream, and every conference that you go to these days, there will often be a section on fertility preservation. Sadly, that isn't really the case in oncology conferences, I think, and while we have here, this is an example of something that, unlike what Anja Pinborg highlighted today, that something that the National Institute for Clinical Excellence in the UK has perhaps done badly in other fields, in this one I think it's to be congratulated, because it highlights that this is something that we, as reproductive medicine specialists, should be engaged in with our patients, and is part of standard care these days. They start off, though, with patients diagnosed with cancer who wish to preserve their fertility. And of course, that is actually a number of steps away from where this should really start, which is actually, of course, with our oncology colleagues, because they need to broach this in the first instance, or the oncologists, the oncology nurses, in that context. And we tend to get patients then referred down the road. And of course, we can only see patients once they've had that information. And so this ought to start, as I say, sometime prior to that, at the time of cancer diagnosis, rather than when it may or may not already have been discussed. And I think that is actually where, in many countries, and the UK is certainly the case, where the bottleneck happens and that patients don't get referred as quickly or as discussed these things as much as they should be, because oncologists are not up to date with what we can offer, and they have trouble getting their heads around the fertility conversation with patients, particularly young patients. They have got a pressing life-threatening diagnosis to deal with, and getting them on board to talk about these things is, I think, one of the major challenges in this field. But they do, in this document, discuss some very important issues that help shape our conversations about this. And there are other documents that highlight the importance of this, as I say, even in the pediatric context where it remains experimental. And this is the Scottish Intercollegiate Guidelines Network document from that same year, 2013, highlighting the good links, the conversations that need to be had, the rapid access between pediatric oncology and fertility, and also highlights that ovarian tissue cryopreservation is something that patients need to be able to have a conversation about and able to think about. As I say, there remain challenges in this. This was an editorial that Melanie Davis and I had published a year or so ago, and it highlights, I think, the awareness amongst our oncology colleagues remains a barrier, and we see that locally in our own service, is that there are particular niches of the oncology services where we really struggle to get them to refer in a timely and efficient manner. Others, of course, do it brilliantly, but there remains some hotspots of difficulty. Funding, of course, remains a major issue for many countries, many patients in this field as well, although that's something that will, of course, vary very much according to the health service that you individually work in. But I again want to just highlight that this whole process of this discussion, discussing both the impact of cancer on fertility and what you can do about it, is a really empowering conversation for patients. Not only because they can then make that decision, but it also very much brings home to them that you are talking about long-term survival here with these patients. And, this is not just, oh, we're going to treat you, you're going to get better. We're suddenly talking about something, you're going to do this when you are better, when this is all behind you. And that is a really powerful message to get across to our patients. So how might we go about when they do come to us? What are the issues that we are going to be wanting to discuss this? And if we're going to do this, we need to be doing it, and of course this is the title of the conference, in an evidence-based way, and therefore we need to have accurate information to be able to give to our patients. And a lot of that will involve discussing about what treatment they're going to have. There'll be some issues about the practicalities of how quickly, how efficiently this can be done, and I'll come on to some of these other things in a minute. But I think it's important to remember that for many patients with cancer, they will retain their fertility. They will go on and have the children that they want to. It is not necessarily a completely terminal fertility diagnosis. But most of the data we have on this actually comes from the pediatric survivorship literature, from the big studies such as the United States Childhood Cancer Survivor, where now for actually several decades they have been following up children, and they use their siblings as their control group in all these studies. They've been following them up, and increasingly detailed analyses, and such as this one that was published a couple of years ago now, that just looks in enormous detail at the chemotherapy regimes that young women, and indeed the other half of the paper talks about young men, what they had, and their chances of cumulative incidence of live birth. So fantastic to see live birth as the outcome of these oncology studies. And you can see that actually the lines are very close together until you get to these relatively older age groups. And part of that will perhaps reflect the impact of age on female fertility, but also I think we need to remember that these are childhood cancer patients, and by the time they're getting into their 40s, that means that the regimens they were treated with were actually 20, 30 years ago, and of course these things have evolved hugely over that period of time. And so from this type of study, we can build up tables such as this that are undoubtedly of value, but we need to remember that these are all some of them have clearer or less clear dose-response relationships. They're often given in combination, and of course they're evolving all the time. And in the context of a pediatric service, what you're giving now will be impacting on fertility in perhaps a decade's time. So actually getting the data on this is really, really challenging, and why studies such as that USCCS are of such enormous value. Another type of analysis that actually is also starting to become available to us that is also is hugely valuable is this one, because one of the problems with the USCCS is actually it has intrinsic bias in it, in that they are selected patients. Many of these outcomes are actually self-reported, so that fertility outcome is actually a questionnaire. These are not necessarily completely unbiased analyses. But this study is an attempt to do this in Germany, where they actually compare all young women who had been treated for Hodgkin lymphoma, and they compare them with national norms. So you have here the red, the cancer patients, and B, the German population. And again, you can see that actually the cancer survivors have exactly the same chance of having a child, and there are limitations in that, of course. It doesn't mean that they didn't take longer. It doesn't mean that they'd actually complete the family size they want, but at least the chance of having a child is actually overall identical to the German population, other again than in these older groups who perhaps were treated with what are now historical regimens. But when you drill down on that, as the appalling phrase has it, and look in a bit more detail, what you highlight is some treatments do remain very damaging, and particularly in this study, they highlight the major impact of radiotherapy to the pelvis. But in a whole lot of other analysis, you can see that even these nasty alkylating agents, they were only had a demonstrable effect at the highest possible doses. And this has been a consistent finding of a lot of these childhood studies, but of course this will not necessarily be the same for if you're treating 25, 30, 35-year-olds as when you're treating a bunch of 10, 15-year-olds. In the adult literature, we actually have much less data about fertility outcomes. There's really a huge dearth in this field, and that's an area that's, for the up-and-coming people who are thinking of new projects to do, this is a fantastic area to get your teeth into. Most of the studies use surrogate outcomes. This one, for again, Hodgkin lymphoma, this is looking at POI, menopause before the age of 40, and it's a very useful analysis because it highlights the huge difference between the different treatment regimes that women might be getting. So ABVD, standard treatment in the UK, at least for even in quite advanced Hodgkin lymphoma, has absolutely no apparent increased risk of early menopause. Doesn't tell us about fertility, but certainly appears to be reassuring. But even within this type of analysis, or this particular analysis, although they tried to identify every female survivor and 2,000 women in the UK, actually they only got data on 50% of them. So again, there is opportunity for bias in some of this. I want to highlight as well that this whole question of what fertility we do have, there actually are quite a number of studies now coming out looking at the fertility of patients who have gone through fertility preservation, and they tell a similar and very consistent story that actually most women will be fertile. And this is one from Copenhagen, where they followed up women who had had one ovary removed and then of course gone on through their cancer treatment, and you can see that the chance of having premature ovarian insufficiency was actually generally very low. Only 9% for the women who they saw for fertility preservation who had had breast cancer. Of course, the exception is the leukemic patients who had had bone marrow transplants, but otherwise a very positive, a reassuring thing. And when they looked at the fertility of these women, 72% had gone on to be able to have children without any further medical intervention. So if you're going to think about, fertility preservation as an intervention in a clinical trial, this is your placebo effect. This is your control group has got a 72% positive response. So you've got to get better than that, or identify women who are particularly at risk to try and bring that 72% down to those who really are at risk of losing their fertility. So to try and sort of fill this gap a bit, we've been involved in an analysis looking at the Scottish population databases to try and get an idea of what is the actual outcome of pregnancy chances in women with cancer in an unbiased population. And we have the opportunity in Scotland to do that. We're linking our cancer registry databases with our maternity databases. And this is some unpublished data I was going to show you in the next couple of slides that illustrate that. So what it highlights, so this is now 23,000 women with cancer over a period of time going back to the early 1980s. And it shows a substantial reduction in the chances of women at any age from 0 up to their 40th birthday of having a pregnancy after a cancer diagnosis compared to the general population. And you can see here, this is the number of effectively missing pregnancies that have not happened in Scotland over these 30 years because of a cancer diagnosis. And you can see that cervical cancer and breast cancer make up nearly half the impact on non-pregnancy of cancer diagnosis. But it's across the board. Every diagnostic group has an impact on a woman's subsequent chances of having a family. When we look at women who have not been pregnant before, who are wanting or trying for their first pregnancy, we see perhaps an even greater effect of about half the chance of having a first pregnancy after a cancer diagnosis compared to the general population. But this has really changed dramatically over time, and also varies very substantially between diagnoses. So if you look here at 3 common situations, 3 common diagnoses, breast, Hodgkin's, cervical cancers, making up a major contribution of our workload in fertility preservation, you can see how between the 1980s and now, the chances of having a first pregnancy have increased substantially. And you need to just remember that the green data here is women diagnosed in the most recent period of time, so actually they haven't probably fulfilled their full potential. But this, and of course, in the early years after cancer, there's a greater deficit than there is later on. But you can see, nevertheless, a very dramatically improving situation for these common cancers. Sadly, that is not across the board. And actually, if you look at leukemia or brain CNS cancers, there's been absolutely no improvement in the fertility prognosis of patients with these diagnoses over 30 years. And this may reflect, as I say, particular treatment aspects with leukemia, and it may affect the wider social issues in these brain CNS cancers. But you can see it's depressing that this has really not changed. And this, I think, highlights where our efforts really need to be focused to try and turn that around for these relatively common situations. Going back to this slide, another point I wanted just to highlight from that is that this is across all diagnoses. And you may think, well, actually, that's a bit strange because, you can see skin here, the 3rd most common impact on non-pregnancy after cervical and breast cancer. It's the 3rd most important diagnosis. And you say, well, why is that? That's not going to affect your fertility. And perhaps the issue here is that this is not a biological effect on reproductive function. It's changing the way women think, that they've been through a cancer diagnosis, and that changes their perspective on life and their perspective on family, and perhaps they no longer want to have another child, because many of these women will have already had a child or 2. So this is perhaps more women choosing not to complete their complete their family, because they've had this potentially life-threatening diagnosis. So there's a whole range of issues, not just the biological fertility things, but the social and psychological issues to bring into this as well. What about some of these other issues that might impact on a woman and how we might advise her? Well, of course, we're aware that the whole concept of age and loss of reproductive function are intrinsically intertwined in female reproduction. And we might consider how we have an individual lady here who's about 20-ish, and she's going to go through treatment that's going to cause her to go through an early menopause. But can we distinguish her from the lady sitting next to her, who actually has got rather better stocked ovaries? And will she have a better outcome just because she was lucky enough to have more eggs in her ovaries when she was born, and therefore they're more likely to stand up to the impact of the chemotherapy that she's going to get? So we can think about this in terms of this journey, this loss of ovarian function during cancer therapy, and then this variable recovery afterwards. So the question is, are the biomarkers that we have, can they really shed insight into this? And of course, again, the problem here is linking surrogates of fertility, of ovarian function, rather than actually fertility itself. And those are the outcomes that we really don't have. But we still can use them, I think, with some value. And so here's a very small girl with a neuroblastoma measuring her AMH, and you can see how during treatment it becomes undetectable. And over a year later, it has remained undetectable. So this girl, even though she's still only about 2, you can probably predict that she's not going to go through puberty. She's going to require egg donation, provided her uterus hasn't been irradiated. So her fertility will not be intact. Whereas perhaps for this other young girl, similar age, you can see a very nice recovery. And the question then is that really reassuring? Or how accurate are we able to actually use that information to be able to highlight to this girl how well she's going to do? And by the time she gets into being a teenager, perhaps she will actually be more in a position like this girl, already gone through puberty, but you can see after treatment, 2 years after treatment, her AMH is still a lot lower than it was beforehand, and then one would anticipate this is going to have a significant impact on her reproductive lifespan. And this actually then raises another whole question that I think in the field we are only starting to get to grips with, and this is the need for post-cancer fertility preservation for young girls like this, who will present at the age of late teens, early 20s, and they'll say, well, look, I'm not going to meet Mr. Right for a good time yet. What can you do to make sure that I can have that baby I want when that time does come, and pick up these few eggs that I still have? So what about prediction? Can we actually, at the time of diagnosis, can we try and identify that? Much like Anna and Bella on that slide I just showed you. Well, of course, they're at the same age, but we know that age has this enormous impact. So this is a demonstration of the effect of age on the chances of having ongoing ovarian activity reflected in menstruation in women with breast cancer, going from really quite a good chance if you're under 35, absolutely falling off a cliff, down to very low chances by the time that you're in your 40s. And you saw this graph earlier, and what I'm highlighting here is how when you just look at the women in this same childhood cancer survivor group who have not managed to have a baby or not tried to have a baby by the time they're 30, you can see that although the overall impact is modest, by the time you get into even your normal reproductive age span, as it currently is in society, you can see then the deficit is already being amplified. So we know that age, we can't do anything about it, but we know that that's an important thing. Other biomarkers, well, this is data from Irene Su, again looking at breast cancer, highlighting that these other factors also predict your recovery of ovarian function after chemotherapy for early breast cancer. So having an AMH over a certain level and your BMI also seems to impact. And we've done some similar work, again, in early breast cancer, highlighting that you can put together age and AMH to actually, between them, fairly accurately predict whether your ovaries will survive the chemotherapy you're going to have for early breast cancer. So can we actually try and use this? And this is all very well, and perhaps these things are things that we need a lot more data on, but where are we in terms of actually being able to use things to actually guide our patients and say, yes, this is an intervention you really need, or maybe things they'll probably work out without. So when we first set up ovarian tissue cryopreservation at Edinburgh, we set up some criteria because it was an experimental treatment. It remains 30 years later or 25 years later an experimental treatment. So much like any clinical trial, you need inclusion and exclusion criteria. And we recently had the opportunity to actually go back over this length of time and see whether these criteria allowed us to identify the women or the girls, this is a pediatric analysis, whether the girls really were, we could identify those at greatest risk. So essentially, what the question was, are the girls that we've offered ovarian tissue cryopreservation to really at substantially higher risk of premature ovarian insufficiency than the girls who we were essentially more reassuring to. And we had the opportunity to do this because we had a central referral centre where we saw every child with pediatric cancer over this 15-year period. So we knew what the unbiased denominator was. And essentially, yes, we had been offering it to patients who were at much increased risk. So the 90% odd of the group where we had not offered it to, you can see actually only one girl out of that whole 376 we were able to identify had developed POI, whereas in the ones we had offered it to, only 10% of the population, you can see that actually 35% of them had already got POI, already had evidence of that. And of course that will both, I'm sure, will increase with time, but it shows that actually you can, with these types of criteria, identify patients who are at high risk and give them more focused advice and be more reassuring to the rest. So to conclude then, I think what I hope I've illustrated to you is this is very much a mainstream field these days. This is something that I'm sure all of you are seeing in your daily practice. And I think what is very clear is that absolutely all these patients need discussion and assessment, and that is a major part of their cancer journey these days, is to have a discussion. Of course, what we really need for that is to join up thinking with our oncology colleagues to make sure that they refer patients, they have the same conversations with them as we're going to have, and that it's a seamless process. What isn't quite clear is how much we need interventions in this patient group. And what we need really is much better information to be able to allow our patients to make that informed decision that they're then going to be happy with and will then serve them in good stead many, many years down the way. And we really need to build on our databases to actually improve our information about all this. And then eventually, one hopes, we'll be able to get some truly informed patient consent about what patients really want to do in an informed way and allow us to offer the best effective and indeed cost-effective care. So thank you for your attention.
Thanks for the great talk, Richard. Our time is over, but maybe we can open to one question.
Thank you, Richard. I have a question. So, regardless of the fact that a woman may or may not make use of the reproductive lifespan that is left after after her treatment, I was wondering, would you advise or would you consider ovarian storage, not oocyte, just to extend a little bit the years before menopause, not so much to reproduce, rather to offset an early menopause.
For endocrine replacements.
Exactly.
Yeah, well, that's an interesting area that's starting to be discussed a little bit as to whether freezing pieces of ovary and put them back, and you might be able to put them back relatively simply, you know, in a non-pelvic location. I think that certainly has its attractions. You know, one hopes that the ovary is very good at making the right steroids that the body really needs, better than a pharmaceutical company. But I think one of the key issues, the two key issues with that is how long it's going to last and how effective it's going to be. And I think well, there's obviously the potential for malignant contamination as well. But in terms of efficacy, it's going to have to produce the right level of estrogen over a decent length of time, and of course it's going to have to produce the right amount of progesterone to provide endometrial protection as well. And there's certainly the evidence that heterotopic ovarian transplants can do that. How well they can really provide the endometrial protection, I think, is very unclear at the moment. But certainly there's a great opportunity for a lot of very interesting work, and maybe the fluctuations in steroid levels that women normally get, it may be that actually we'll learn a lot about how normal that is and how good that is for normal functioning.